My name is Robert Lager. I'm an interventional cardiologist. I trained for medical school at University of Pennsylvania at UPenn. I did my residency at Massachusetts General Hospital in Boston, and my fellowship also in Boston, Beth Israel Deaconess Medical Center. A lot of the procedures now, because they're minimally invasive, they don't seem like a very big deal. They really are a big deal. I mean, they're significant risks and there's significant benefits. Transfemoral approach is basically getting access through the groin artery, the femoral artery. And we usually use a slightly larger tube or sheath to go into the femoral artery and bring our catheters up through the groin, up to the heart. Transradial approach is via the wrist, the radial artery, which is just below the thumb. We use generally smaller catheters to do that, and we navigate the anatomy through the arm to the heart. Radial intervention and radial angiography I think it's a really exciting step forward for a couple reasons. We talk a lot about safety, talk about the lower risk of bleeding, which at the access site, it's clearly much safer than the femoral groin approach. And we talk about potentially particular groups of patients who are at highest risk of bleeding. But I will tell you this, that you take all the safety benefits away. Let's say it was just as safe to do it from the groin as from the wrist. The patient satisfaction is just through the charts, through the roof. It's off the charts because it's so easy to do for the patient. There's so little discomfort, and the recuperation right afterwards. One of the major, I think, areas of difficulty for patients after these procedures is laying flat. Sometimes 8, 10, 12 hours after procedure. People with bad backs, it's miserable. And through the wrist, you can sit where you can walk off the table.